In this video, we'll discuss briefly about HIE in preterm neonates. The full video on HIE in term and preterm neonates is on our YouTube channel. You can go check it out. This is the most important topic, that is preterm neonates. That is born before 36 weeks. When severe asphyxia occurs, the area involved are again thalami, dorsal brainstem, anterior vermis, etc. What areas are spared? Areas like perirolandic cortex and basal ganglia are usually spared in this because they show late myelination. So in term neonate they are myelinating, hence they are damaged. In preterm they are not myelinating yet, so they are less likely to be damaged. Next, we'll use modalities like ultrasound and MRI. So what are the ultrasound findings in a preterm neonate? This can be used within 48 to 72 hours. There will be increased echogenicity in thalami. MRI will show again diffusion weighted imaging within 24 hours will be positive, peaks in 3 to 5 days, and the findings will pseudo normalize at the end of first week. On day 2 we can see T2 weighted imaging, there will be T2 prolongation, that is hyperintensity in thalami. On day 3 we can see T1 shortening, that is again hyperintensity, which will be seen up till chronic stages. That means it is persisting till advanced stages of the disease. Next we'll move on to the most important topic, that is preterm neonate partial asphyxia, that is mild to moderate asphyxia, lesser degree of damage for a prolonged time in a preterm neonate. First important topic is intraventricular hemorrhage. This is what occurs in partial asphyxia. So the prevalence is inversely proportional to gestational age and birth weight. That is, if less gestational age and less birth weight, more involvement. What happens here is germinal matrix hemorrhage. First we will see what is germinal matrix and why hemorrhage occurs in the germinal matrix and not other areas. Germinal matrix is the lining of ventricles which is present in the preterm neonate. This will later give rise to neurons and glial cells, and it will involute by the time there is 34 weeks. So this germinal matrix, the last to involute, is present in caudothalamic groove. What is caudothalamic groove? Here is the caudate nucleus and here is the thalami on sagittal section from anterior fontanelle. This is the caudothalamic groove. So germinal matrix is present here even in preterm neonate, last to involute. That's why this is the most common site for germinal matrix hemorrhage. Grading of intraventricular hemorrhage. Grade 1 there is only germinal matrix hemorrhage. Grade 2 there is intraventricular hemorrhage without hydrocephalus. Grade 3 there is with hydrocephalus. And in grade 4 there is parenchymal extension of the hemorrhage, that is intraparenchymal hemorrhage is also present. We will see one by one with images. This is grade 1. This is sagittal and coronal sections. Here you can see hemorrhage only in the caudothalamic grooves, that is germinal matrix hemorrhage. So here we can see the hemorrhage which is hyperechoic. This is grade 2 where there is intraventricular hemorrhage without hydrocephalus. Now grade 3 shows hydrocephalus, also blood clot can be seen here, that is hemorrhage present. And grade 4 there is intraparenchymal hemorrhage. Next most important subheading will be periventricular Leukomalacia. This is also called as white matter injury of prematurity. The reason why periventricular areas are involved is because of relative hypovascularity of white matter along the periventricular regions. So that's why it undergoes hypoxia more. So most importantly affected areas are the trigones and the white matter adjacent to the foramen of Monro. We see on ultrasound. On ultrasound we can see something called as periventricular flares. You would have heard the term periventricular hyperechoic areas, that is seen within 48 hours. This shows congestion of the blood vessels around the periventricular region. This will normalize by 2 to 4 weeks. So these periventricular flares can progress to periventricular cysts in 3 to 4 weeks if the damage is persistent. That will later progress to end stage periventricular leukomalacia by 6 months. So on MRI we can see T1 hypointensity in periventricular white matter. On T2 weighted it appears hyperintense. What does end stage periventricular leukomalacia mean? On ultrasound MRI there are same findings. I'll show on MRI what are the findings. First one is reduced white matter volume which can appear hyperintense. There is dilated ventricles. This is permanent dilatation. There will be irregular outline of the ventricles. There can be some few persistent cysts in periventricular areas. There can be atrophy of the brain matter also. This is briefly the use of MR spectroscopy in HIE. This can be used within 24 hours just like the diffusion sequence. There will be lactate elevation which shows two peaks. One is immediately after damage, one is 24 hours to 48 hours after damage. Peak will be at 1.3 ppm in 1.5 Tesla machine. Peak can be seen in deep grey nuclei and parieto-occipital lobes, also in watershed zones. Another peak to be looked after is the glutamate peak, which is at 2.3 ppm in 1.5 Tesla. Overall, the algorithm for working in HIE for imaging is, if a patient is suspected for HIE, then neurosonography or ultrasound of cranium has to be done as the first imaging modality. So if it is positive, then diagnosis is confirmed, taken up for treatment. If it is negative, then further we have to go for MRI. Depending on the duration, we can use diffusion, T1, T2, any imaging sequence. If it is positive, again diagnosis confirmed, go for treatment. If it is negative, we can use additional sequences like MR spectroscopy, or we can go for a repeat scan after 2 to 4 days to confirm the extent and the findings. So for more such teaching videos, please follow our page on YouTube and Instagram at Radiology Doodles. Comment if you want any videos.